And first of all, I'd like to thank Dr. Piazza, Goldhaber, and the rest of the NATF board for giving me this opportunity. I must admit, though, that when Sam proposed a title of my talk to be Hospitalist, Role Model, and Educator for VTE Best Practices, I did a lot of head scratching to try to think about what content I was going to deliver. And in the end, I decided to be a little bit provocative and broad and pose a question to you. Is a 15-year-old, or should I say young specialty, a leverage point to improve U.S. healthcare, or as we talk specifically today, VTE best practices as an example of quality improvement efforts? And so that's sort of my goal today, to sort of head down that path. To do so, there are really three primary areas I want to cover. First is to review some context and to just talk in broad strokes about our current healthcare environment and what that means in terms of a need to improve quality care delivery. Then, more specifically, I'm going to talk about why hospitalists must be champions in quality improvement initiatives in the inpatient setting. And to do that, many of you may not be intimately aware who hospitalists are, how we're incentivized, and sort of what the future of hospitalism is. And then finally, we'll sort of end talking about using VTE prevention as an example. What specific action steps do we need to take to better VTE best practices? And I'll share with you sort of my three golden guiding principles in quality improvement efforts that you'll see all of these award winners implemented in their VTE prevention efforts. Well, first let's start broad, and let's talk about U.S. healthcare, sort of a mild topic of conversation currently in the United States. And that's because in the United States we spend an enormous amount of money on healthcare, over $2.6 trillion a year, which is about $8,000 per U.S. citizen, the highest in the world. This represents a threefold increase in spending on healthcare in the past 20 years, and currently we spend more money on healthcare in the U.S. than we do on food. This represents about 17% of our gross domestic product, and importantly, over a third of all healthcare spending occurs in the hospital setting. So that's a prime area to focus opportunities, not just to improve quality, but to also reduce costs. Well, the high amount of expenditure is projected to become even greater, with really rapid escalating healthcare costs that by the year 2019 we'll see another 70% increase in our government healthcare spending, and the percent of our gross domestic product will rise from 17% of our GDP to 20% of our GDP. Really and truly a rate that is not sustainable. So one of the fundamental questions that I think that we first have to ask is, what kind of return on investment are we getting? In other words, if we're spending a lot of money, what kind of quality are we receiving as a healthcare environment? And I think first the good news. The good news is that we've come a long way. Sort of paying tribute to a couple of Harvard professors, back in 1835, Dr. Jacob Bigelow stated that the amount of death and disease would be less if all disease were left to itself. Well, by the early 1900s, we'd made enormous strides and actually turned the corner, so that by 1912 was the first time in human history that a random patient with a random disease consulting a doctor chosen at random stood a better than 50% chance of benefiting from that encounter. Well, our quality of care delivery from 1912 to 2010 has continued to improve. And in fact, I'd argue that we routinely achieve miracles with our healthcare spending. Consider that between 1960 and 2010, we've seen an 8-year life expectancy gain. We've cut mortality from heart disease and stroke by 50%. We've seen a 15% increase in 5-year survival with invasive cancer. And last year alone in the United States, over 25,000 organ transplants were performed. So we spend a lot of money and we routinely perform miracles, yet lurking beneath the surface is a fundamental problem with our systematic care delivery. And one of the challenges is that we continue to have knowledge discovery occurring at a more and more rapid pace, one that becomes very, very challenging to deliver what we're learning and the best practices to patient care delivery, and to do that routinely, systematically, and without fail. And in fact, when you look at how often we deliver scientific evidence-based care to our patients, whether it's preventive efforts or treatment efforts, the best evidence says we get it right only about half the time. So there's enormous opportunity to try to do better in this regard. Well, more simply put, although we routinely perform miracles, we oftentimes fail to do the simple things well. As examples, we do not control blood pressure adequately in the outpatient setting about half the time. We only achieve recommended colorectal cancer screening about half the time. We only implement stroke prevention strategies in patients with atrial fibrillation about 60% of the time. And as today's focus on DVT and pulmonary embolism prevention, on a broad-based sense, we only deliver appropriate prophylaxis to patients about half the time. So we have a lot of work to do to try to improve care. And it's important to recognize that this failure to deliver systematic care has major consequences to our patients in terms of morbidity, mortality, and overall costs. A couple of examples. When we make overt medical mistakes in the United States, that leads to between 40 and 98,000 patients dying from overt medical errors in the U.S. every year. But errors of omission are probably equal, if not more culprit. Consider that inadequate care after a heart attack, for example, failure to prescribe beta blockers or antiplatelet therapy, leads to an estimated 18,000 unnecessary deaths in the United States every year, and up to 100,000 patients die from potentially preventable pulmonary embolism in the U.S. every year. Again, sort of shining a bright spotlight on programs like this that are focused on DVT prevention initiatives. So we spend a lot of money. Yes, we perform miracles, but we've got a lot of work to do to systematically improve care delivery. And that sort of leads to all of the political wrangling and rhetoric that we see in the news every day. But I think it's important to not lose sight of how basic and fundamental our goals are. Whatever changes occur with healthcare, as providers and people engaged in the healthcare system, we need to recognize that our goals are very simple. One, patients should receive care based upon the best available scientific evidence. That's simple, and I think something that we all think that we do every day. But we must realize the challenges in doing that and delivering that best practice care systematically and without fail. And that's really where our areas of opportunity are, is to how do we hardwire our practices so that we take that best available evidence, and whether we deliver it to our patients or not is not sort of prone to chance, but rather hardwired, and we do that systematically and without fail. Well, on a national scale, I think everyone recognizes that there are a number of what I call regulatory drivers to try to incentivize, penalize, and guide us to redesigning our systems so that we deliver that systematically and without fail. Where really the basic goal of these drivers is pretty simple. If we're going to get higher return on our healthcare investment, we can do so by increasing quality or decreasing cost. Usually if we improve quality, costs actually fall along with that. And so to help guide us, we have things like accreditation, pay for performance, increased transparency by data sharing, value-based purchasing initiatives, and most recently, the Accountable Care Initiative. So one of the challenges, though, is how do we take these regulatory drivers on a national sort of perspective and actually impact change at the local level? And I'd argue that for us to be successful with these initiatives, we must have and identify champions that can deliver and these systematic changes to our healthcare system. And that's where I want to introduce you to a group that's near and dear to me. I've been a hospitalist at the University of Utah Medical Center for the past 11 years and have seen sort of a remarkable growth of hospital-based medicine. And I want to talk with you a little bit about the hospitalist movement, sort of what the foundation of hospitalists has been, but probably more importantly is absolutely what the future of hospitalism must be to meet our current healthcare challenges. Well, hospitalist is a very new field and specialty. Just 15 years ago, Bob Wachter and Lee Goldman anticipated the rapid growth of a new breed of physicians they coined hospitalists, specialists in inpatient medicine, who will be responsible for managing the care of hospitalized patients in the same way that primary care physicians are responsible for managing the care of outpatients. Well, in just 15 years, there has been a remarkable and exponential growth in hospitalist physicians, a growth rate unparalleled of a specialty in medicine, 30% growth rate per year, every year over the past 15 years. Currently, there are over 30,000 practicing hospitalists in the United States, which makes hospitalists the largest internal medicine subspecialty. And as you would predict, with increasing numbers of providers and scope, the percent of patients that hospitalists care for has risen dramatically along with that. Well, currently, well over 40% of hospitalized medical patients are cared for by a hospitalist physician like myself. But what many people don't realize is that hospitalists don't just care for sick medical patients, but in fact, hospitalists take care of over 40% of orthopedic surgery patients and nearly 40% of all surgical patients. So the scope of hospitalists is one of multi-specialty. We cross all specialties in the hospital, which when we look at broad-based quality improvement initiatives, puts us really in sort of a wonderful position to impact change. Well, the house that Hospitalist was built on is really, at its inception, about efficient care. And the growth of the hospitalist movement has purely been predicated on a hospitalist's ability to navigate the healthcare system, to be available in real time, to allow shortened lengths of stay. And so hospitalism was not founded on improving quality of care, but rather improving efficiency of care without sacrificing quality. Well, hospitalists have helped achieve that efficiency goal, where we've seen a continued reduction in hospital length of stay. Importantly, though, that reduction of length of stay was well on its way before hospitalists took off. We started seeing downward trends through the 70s, 80s, and 90s. But currently, we're nearing sort of peak efficiency in many hospital settings, where 60% of all hospitalized patients in the United States are in and out of the hospital in less than 3 days, and 85% are in and out of the hospital in less than 1 week. So hospitalists have helped accomplish its original goal, that of maximal efficiency. But I'd argue that that actually puts hospitalists in a vulnerable position as we move forward in the next couple of decades. One of the reasons for that is money at most of our hospital settings is getting tighter and tighter, and people are asking more and more what at the local level the return on investment is. And something that I think a lot of people don't realize is with the current payer mix in the inpatient setting, most hospitalists can absolutely not survive on their clinical productivity or their billing alone. In fact, over 90% of hospitalists in the United States receive a financial subsidy to augment their clinical activities. Oftentimes that financial subsidy comes from the hospital or the healthcare system that the hospitalist works in. And last year, the average hospitalist subsidy was about $110,000. So that's good on one hand, but if you have your administrators continuing to ask, what have you done for me lately, it puts you in a vulnerable position. And so if we look at areas, though, that hospitalists are currently incentivized and what aligns with hospitalists, by far the number one subsidy and incentive goes towards productivity, but we talked about that. There's a ceiling to how many patients I can see and how efficiently I can move patients through the healthcare system. There's a smaller amount of subsidy and incentives for administrative responsibilities. Again, a limit to how much administrative work one can do. And really the core area of opportunity that hospitalists must capitalize on, and one that has an infinite area of opportunity, is that of quality and performance improvement. So for me, this is the future of hospitalist medicine. In the inpatient setting, by caring for a majority of patients across multiple specialties, but being in a financially vulnerable position, hospitalists must embrace the opportunity to not just focus on efficiency, but also to lead and champion quality improvement initiatives. So for me, sort of the hospitalist model in 2011 beyond is really a diverse one, where still the core foundation of hospitalists is to deliver efficient, compassionate, evidence-based care, but also recognizing opportunities to develop true specialty areas of expertise. Like, for example, our hospitalist group, we have a diabetes component, pain and palliative care, and an anticoagulation or thrombosis component. But along with that foundation needs to have pillars such as quality improvement, active engagement and championing better practices, understanding the business and administrative aspects with that, tapping into our electronic medical records and information technology to allow us to be successful, and then at the local level being absolute champions and educators for making these system-based changes. Well, that's sort of my context and my plug for champions, for hospitalists being champions. So I think the first take-home point is when you go back to your hospitals and you're looking to improve performance improvement like DVT prevention, you must engage your hospitalists. They're prime, ready, and should be willing and able to help in these types of initiatives. And DVT prevention really represents the absolute perfect case example of how to sort of invoke performance improvement principles and have hospitalists be involved in that charge. Well, part of the reason that DVT prevention is such an wonderful initial opportunity for performance improvement is the scope of VTE. 700,000 patients are hospitalized every year with VTE, and 100,000 deaths occur. With our aging population, the current projections are that VTE events may double by the year 2050. And importantly, over half of all DVT and pulmonary emboli in the United States are associated with hospital setting, acute illness, surgery, or admission for medical illness. And in fact, fatal pulmonary embolism accounts for about 10% of hospital-related mortality. But the good news is that we have 4 decades of clinical trials looking at the effectiveness of DVT prophylaxis strategies that will reduce VTE risk by about 60%. So if we think in terms of broadly what that means that the systematic, and I underline systematic, application of preventive strategies to at-risk medical and surgical patients could reduce the burden of VTE in the United States by 50% and literally save thousands of lives. So this is an unbelievable opportunity to improve patient care and along with that, reduce costs. Yet, despite 4 decades of clinical trials, we continue to not adequately deliver prevention strategies on a systematic basis across the United States. And every year or so, or actually now every quarter, I keep looking for studies that are going to show broad-based perspectives that were really moving the needle and were prophylaxing more appropriate patients. But in fact, every quarter when I look at the literature, I'm disappointed that we still, again, nationally get this right about half the time. So there's still an enormous amount of work that we need to do to improve care in this area. Well, as we sort of started with in terms of what's the government response when we have areas of opportunity in healthcare, well, the government response is those regulatory drivers again. And in VTE, there have been a number. The Surgical Care Improvement Project, which one component focused on VTE prevention in surgical patients, the National Quality Forum, Value-Based Purchasing Initiative, not paying us for DVT and PE events that occur after major joint replacement surgery, and then most recently, the Joint Commission approved performance measures trying to drive us to delivering and meeting this need of VTE prophylaxis. So when we look, though, at how we go about meeting our goals of having patients admitted to the hospital with prophylaxis ordered or documentation justifying its absence, that's where we need to figure out how we actually spring into action. And as a hospitalist champion, I think this taps into basic quality improvement principles that are very true in VTE prevention, but also applicable to other quality improvement initiatives that we may take on. And importantly, these three principles you'll see in all of the success stories of the DVT hospital award winners employed all three of these. And that is, if we're going to be successful in DVT prevention, we must have multiple points of attack. Less is more. And if we think we're going to get it right the first time, we're wrong. This is quality improvement where we must try again. So I want to go through these three core principles as it relates to DVT prevention. Well, on a broad sense, if we look at how do we actually go about improving quality in a hospital setting, in the end, we can motivate and we can enable. We can motivate individuals by awareness, right? Talking about the magnitude of DVT and patients who die of fatal pulmonary embolism. We can enable individuals by designing order sets, having reminders, etc. We can motivate groups of practitioners, nurses, pharmacists, and physician groups by making our data publicly available, having transparency or audit feedback mechanisms, and we can also sort of push people to do the right thing with those regulatory drivers. We can enable groups of people by educating them about what steps are necessary to be successful. And then importantly, we can and must design structural elements that align rewards and accountability and that tap into other support mechanisms like our IT services if we have a hospital with an electronic medical record, or perhaps other support services like an anticoagulation service. But what's important is when we're trying to accomplish something like DVT prevention at a hospital level, we must hit this grid in as many places as we can. And let me give you an example more specifically as it relates to DVT prevention. We talked about the state of nature in a typical hospital setting who has not embraced a need to develop DVT prevention initiatives. And as we would predict, in our state of nature, we're likely prophylaxing about 40 to 50% of at-risk patients. Well, if we sort of draw from quality improvement studies in this area, we know that if we just develop a consensus building team and we develop a protocol, and the protocol is sort of in the catalog of protocols in our hospital setting, but that's all we do, we're not going to move the needle very far. And in fact, we may only improve prophylaxis to about 50%. But if we make that protocol simple and we integrate it at the point of order entry, we can move the needle up to prophylaxis rates of about 60 to 85%. If we combine that with other QI methods such as audit feedback, sharing data, educating the masses, we can improve prophylaxis rates up to about 90%. But one of the things we have to reconcile with is if we're going to be 95% successful, we have to do all of those things plus be creative about adding other high reliability mechanisms, electronic alerts, an ability to get data in real time and act on that. And so the point of this quality improvement principle number 1 is multiple points of attack are necessary, and you'll see that through all of the DVT award-winning presentations. Well, the second QI principle that we need to reconcile is oftentimes less is more. And if we think about how we would approach DVT prevention in broad terms, the initial step is identifying patients who we're going to act on and implement prophylaxis. And there are a couple of ways we can go about doing that. One way is to develop an individual risk assessment strategy. The other way is approaching things from a group risk assessment, basically assuming that the majority of patients are at risk and then identifying the exceptions to that rule. If we have an individual risk assessment strategy, we'll either prompt the initiation of prophylaxis or not. And if not, to be truly successful, we have to embed methods to continually reassess that patient through their hospital stay. And when risk develops, then implement prophylaxis at that point in time. Well, once we have identified a patient in need of prophylaxis, then we have to sort of deal with potential contraindications that are going to alter our management strategy. And as Dr. Goldhaber talked about earlier, as our healthcare system changes and hospital length of stay is shorter and shorter, assessing the duration of therapy also winds up becoming an important element. But with the QI principle, less is more, I wanted to just sort of highlight differences very briefly between an individual risk assessment and a group risk assessment strategy. Individual risk assessment is an evolving science where there is a number of individual risk assessment models that have been proposed. The one on the left was developed by Dr. Goldhaber and his group at Brigham and Women's Hospital and has been used in studies like the electronic alert study and the human alert trial. We have another risk assessment model that was proposed out of the IMPROVE registry, which was a broad-based medically ill registry. And then we have a more complex, detailed risk assessment model developed by Joe Caprini. All of these risk assessment models are effective in identifying very high-risk patients. But one of the challenges is that some of the risk assessment models perhaps lack sensitivity if our focus is on patients who are at, say, moderate risk, where still prophylaxis would be justified. Well, if we contrast risk assessment models to sort of a group approach, the group approach has become popularized at some institutions because of its simplicity. That basically it goes at VTE prevention with a strategy of most patients in the hospital setting are moderate risk, so in essence our default is to initiate prophylaxis, and the only thing we have to do perhaps is identify outliers where we're not going to initiate prophylaxis, or we may perhaps be more aggressive in our prophylaxis. Well, you say, well, why does this matter? Why try to sort of decide what our institutional approach is going to be? And part of this has to do with the QI reliability theory of less is more, where let's walk through this for a minute. The overall likelihood of us successfully completing a DVT prevention protocol is dependent on two things. One, the probability of success of us completing each element of that protocol. And then the other is simply the number of elements or steps or processes involved. Where if we wind up having a 95% likelihood that we'll complete an element successfully, which is very high, that we would predict if we only have to do one single thing as our protocol, our VTE prophylaxis rates will be 95%. But if our protocol involves, let's say, 25 elements, and each element still has a 95% success rate, our overall success in delivering appropriate DVT prophylaxis would only be 28%. Even if we were 99% likely to accomplish each element, if our protocol has 25 elements, we're only going to be delivering appropriate prophylaxis in 78%. So one of the things is that oftentimes, unless you have sophisticated electronic medical record, less is more. Well, and the last and final QI principle that all of the hospital award winners are going to highlight is try again. If we think we're going to be successful in a performance improvement initiative like DVT prevention with our first try, we're mistaken. And I'll give you a couple of examples that hospitalists have driven to illustrate that. Well, at the University of Utah, I was a fresh, naive hospitalist trying to figure out whether eventually I was going to go on and be a cardiologist or a pulmonologist. And in my first year or two of practice, sort of was doing my due diligence in medical literature review and came across the Metanox trial of enoxaparin in medically ill patients. And it raised the question, well, how are we doing in terms of prophylaxing our medical patients at the University of Utah? And back in 2002, we looked, and lo and behold, state of nature theory was true. We were prophylaxing about 40% of at-risk patients. So at that point in time, we knew about QI principles, and so we took a multifaceted approach, and we created a protocol, had broad-based education, we implemented audit feedback, and within a few months, we improved our prophylaxis rates to about 75%. Well, that's when things stalled a little bit because we had a paper-based chart. We had a fragmented sort of system that we were working in, and so we just kept plugging away at awareness and education and continued to slowly move the needle in terms of our prophylaxis rates. Until last year, we had implementation of computer order entry, and so all of a sudden it gave us the ability to easily accomplish the next step, which is less is more, where we could simplify and streamline our protocol and implement it directly and consistently into the point of order entry, and our prophylaxis rates are now close to 90%. So for us, the next sort of part of getting to 95% is taking advantage of our hospitalist workforce to drive absolute systematic delivery of VTE prevention. Well, currently we're 10 years into our hospitalist group, so now our Chief Medical Informatics Officer is one of our hospitalists, the chair of our Medical Records Department is one of our hospitalists. We have myself, who's the director of our healthcare system's thrombosis service. So we have the stars aligned to try to continue to improve on this, where currently we have designed a true decision support, and probably most importantly is an ability to extract data in real time, where you can have a floor-based pharmacist, nurse manager, myself, or physician champion, no matter where you are, log on to a portal and look at that very moment on any given hospital unit or any individual service line and look at what percentage of patients are on appropriate prophylaxis or not, and then importantly drill down in real time to identify those patients that maybe slipped through our protocol. And with that, we're hoping to get our prophylaxis rates again over 95%. Well, part of the reason we've sort of gone about with this high reliability theory is the success of another hospitalist in this area, Dr. Greg Maynard at UC San Diego, where they implemented a 3-year study that again reinforces all of these QI principles. They developed consensus and a multifaceted approach and improved prophylaxis to 70%, integrated the protocol at the point of order entry, improved prophylaxis to 90%, and then overlaid those high reliability theories with real-time data and improved their prophylaxis rates to over 95%. And their success is very similar to the other award winners today, where they showed that through their intervention, their pre-intervention VTE rates were 1 in every 220 hospital admissions, and that decreased to 1 in 1,601 patients post-intervention. So what my goals today are to, one, review quality improvement in general and talk about sort of our healthcare system, that truly we're in an era of necessary change. Second, to reinforce and highlight hospitalists are absolutely a group that must champion efforts like DVT prevention. So for those of you going back to your hospitals, that's your captive audience to help drive change at your institutions. And then finally, to review some basic quality improvement concepts that will allow you to be successful, and again, concepts that will be reinforced by really all of the DVT award winners during their presentations today. So thank you very much.